If you are over 60, there is a good chance at least one of the 9 medications I'm about to describe is sitting in your house right now. Probably in the kitchen cabinet, or in that pill organizer with the days of the week on the lid. And what almost nobody has sat you down to explain is that some of the most ordinary pills we reach for, a few prescribed, a few you pick up off the pharmacy shelf yourself, can slowly push your risk of a heart attack or a stroke higher. No one made a mistake here. The appointment where you got them was 12 minutes long, and there was never time to walk through what they do to an older heart and older arteries over months and years. I want to be fair about these drugs. Every one of them helps somebody. Taken for the right reason, for a short enough stretch, they do real good. The trouble starts with the ones taken for years in a body already past 60, usually alongside 3 or 4 other things. In more than 15 years of internal medicine, I've watched this exact picture. Someone doing everything right. The blood pressure pill taken on schedule, a walk every morning, and a number on the monitor that just will not come down. The reason was sitting in their own medicine cabinet the whole time, and nobody had connected it. 9 medications. 3 of them you can buy off the shelf, no prescription needed, and almost all of them do their damage through the same 4 levers. Pushing the pressure in your arteries up, making your blood quicker to clot, stripping away what keeps your vessels relaxed, or throwing off the heart's own rhythm. By the end, you will know which of the 9 is most likely yours and what to do about it without stopping a single thing on your own. Keep those 4 levers in your head because they are the whole story. Blood pressure, clotting, vessel tone, which is just how relaxed and open your arteries stay, and heart rhythm. Every drug on this list reaches in and pulls on at least one of them, and the dangerous ones pull on 2 or 3 at once. Here is the part that matters for you personally. Most people watching this are not on one of these. They are on 2 or 3 together, and the risk does not add up politely. It stacks. So, as I go, keep a running tally of which ones are yours. The honest goal today is simple. By the end, you walk into your next appointment knowing exactly which pill to ask about and exactly what to ask. One promise before we start. I am not going to tell you to stop anything. Some of these are genuinely dangerous to quit on your own. This is about the question you bring to your doctor, not a decision you make in your bathroom tonight. One quick thing before the first medication. If you are in your 60s or you can feel 60 coming, and what you really want is to live longer, stronger, and healthier, I want you to know where to look. I took everything I tell my own patients and put it into one simple plan. It has already helped thousands of people feel steadier and more in control of their own health after 60. The link is on your screen right now. You do not have to write anything down. Just take a look once we are finished here. The first one is the bottle of Ibuprofen or Naproxen in almost every kitchen in America. We call them NSAIDs, which is just the family name for anti-inflammatory painkillers like Advil, Motrin, and Allergy. Here's what they do that nobody mentions at the register. They make your kidneys hold on to salt and water, which raises the pressure in your arteries. And they shift the balance of the chemicals that control clotting, so your blood becomes a little quicker to clump. Higher pressure and stickier blood from a pill you took for your knee. This is not a fringe worry. Back in 2015, the FDA strengthened the warning on every one of these bottles because the heart attack and stroke risk can show up in the first weeks of regular use, not just after years. The people who get caught are the ones taking them every single day for arthritis or an aching back, often while they are already on a blood pressure pill that is now quietly fighting a losing battle. So here is what to do for day-to-day aches. Ask your doctor about acetaminophen, the active ingredient in Tylenol, or a topical anti-inflammatory gel you rub on the joint, which barely reaches the bloodstream. If you need an NSAID, use the lowest dose for the shortest time, and tell your doctor if you take one regularly and also have high blood pressure. That one sentence in the exam room changes the whole calculation. The second one is in your medicine cabinet every cold and allergy season. Oral decongestants, the pills like Sudafed, and the ones with a D on the end of the name like Claritin D or Mucin XD. The way they clear a stuffy nose is by tightening the blood vessels in your sinuses. The problem is they cannot tell your sinuses apart from the rest of you. They tighten blood vessels through your whole body. So the pressure jumps, your heart rate climbs, and your heart has to push harder against narrowed pipes. For a younger body, that shrugs it off. For a 60-year-old with stiffer arteries, that is a real spike, sometimes a dangerous one. The trap is how invisible it feels. You think you took something for your nose. Your heart is the part that paid for it. What to do is easy, and your nose will not miss a thing. Reach for a saline nasal spray or a steroid nasal spray like the over-the-counter Flonase, neither of which raises your pressure. Read the label on any combination cold medicine, because the decongestant hides inside products you bought for cough or pain. And if you have high blood pressure or any heart history, the oral decongestant is the one cold aisle product to leave on the shelf. The third is the little dose pack of Prednisone, the steroid your doctor hands you for a bad flare of arthritis, asthma, a breathing problem, or a skin condition. Steroids work, and sometimes you genuinely need them, but they pull 3 of our 4 levers at once. They make you retain fluid, which drives blood pressure up. They raise your LDL, the harmful cholesterol that builds plaque in your arteries, and they nudge your blood toward clotting. A 2017 study in the BMJ of more than 1 million adults found that even short courses of these steroids were linked to a measurable jump in heart attacks and clots in the weeks right after. The danger is the person who is on them again and again. A dose pack every few months for a recurring problem with nobody adding up the total over a year. So, here is the move. If you are offered a steroid, ask the honest question. Is there a non-steroid option for this or a lower dose? If you truly need it, keep the course as short as possible and have your blood pressure and blood sugar checked while you are on it. And never, ever stop a steroid suddenly on your own. After more than a few days, your body slows its own production, and stopping cold can put you in real danger. That one comes off only with a doctor tapering the dose. The fourth is hormone therapy. For women, that is estrogen for menopause symptoms. For men, it is the testosterone that gets prescribed more freely every year for low energy and low drive. Hormones change the chemistry of your blood. They make your platelets, the tiny cells that form clots, stickier and quicker to clump. And a clot that forms where it should not is exactly what causes most heart attacks and strokes. This is not a guess. The Women's Health Initiative, the large federal trial back in 2002, was actually stopped early in part because the hormone arm showed more clots and strokes than expected. That does not mean hormone therapy is off the table. For a lot of people, it is the right call. It means the dose and the form and the length of time all matter, and they need a real conversation. What to do if you are on hormones? Ask your doctor about the lowest effective dose for the shortest time that controls your symptoms. For estrogen, the patch or the gel that goes through the skin carries less clot risk than the pill because it skips the first pass through the liver. And make sure your own clot history and family history are on the table, because that is what should decide it. So, if this is the kind of plain explanation you wish you got at your own appointment, the best way to keep it coming is to hit subscribe and give this a like, and leave me a comment with your age and how many of these 9 you are on so far. The age of the people watching genuinely shapes what I cover next, and that running count tells me what you actually need. Now, the fifth one, and it is the one almost nobody suspects. The fifth is the thyroid pill, Levothyroxine, the little tablet that millions of older women and plenty of men take every single morning. The medication itself is not the villain here, the dose is. Here is what happens. Your thyroid sets the speed of your whole body, including your heart. Most people get put on a dose years ago and never have it rechecked. But as you age, your body often needs less. So the dose that was right at 52 is now running you a little too fast at 68. Just slightly too much thyroid hormone, year after year, pushes the heart toward atrial fibrillation, a fast and chaotic rhythm that is one of the leading causes of stroke. Researchers following the famous Framingham Heart Study found that when your thyroid level runs even a little too high, the risk of that rhythm roughly tripled. The tell is a heart that occasionally races or flutters, or a resting pulse that feels quicker than it used to. The fix here is one of the easiest on the whole list. Ask your doctor for a simple blood test called a TSH, and ask the plain question, is my dose still right for my age? If it is crept too high, a small adjustment protects your heart. You do not touch the dose yourself. You just ask for the recheck almost nobody orders. The sixth is the heartburn pill, the proton pump inhibitor, or PPI. These are the purple pills and their cousins omeprazole, esomeprazole, names like Prilock and Nexium, and you can buy them right off the shelf. They are very good at shutting off stomach acid. The catch is a slower one. Over the long haul, they appear to lower your body's supply of nitric oxide, the natural chemical your blood vessels use to stay relaxed and open. Less nitric oxide means stiffer, tighter arteries. A Stanford team in 2015, looking at the records of hundreds of thousands of patients, found that long-term PPI users had a higher rate of heart attacks. They can also blunt a common blood thinner called clopidogrel, which some heart patients depend on. The problem is how these became forever pills. People start one for a few weeks of heartburn and are still on it a decade later. No review, no end date. So here is what to do. If you genuinely need one for a diagnosed condition, that is fine. Keep taking it. But if you drifted onto it for everyday heartburn, ask your doctor about stepping down to a gentler acid reducer or treating the cause with smaller evening meals and not lying down too soon after eating. The goal is to come off the long-term autopilot with your doctor's blessing. The seventh is one most people have never heard of, and it is the heavy hitter on this list: JAK inhibitors. Newer drugs for stubborn autoimmune disease, rheumatoid arthritis, certain bowel diseases, bad eczema. The names end in tinib, like toitinib. I am including this one because the warning is about as clear as medicine ever gets. A large trial called Oral Surveillance, published in 2022, compared one of these drugs to an older option. It found higher rates of heart attack, stroke, and blood clots, especially in people over 50 who already had a heart risk factor. The FDA responded by putting its strongest possible warning, the boxed warning, right on the label. If you have a serious autoimmune condition, these drugs can give you your life back. So this is not about fear. What to do is a focused conversation. If you are over 60 and on one of these, ask your specialist directly how your personal heart and stroke risk weighs against the benefit and whether one of the older, gentler options would control your disease just as well. For a drug this powerful, that is a conversation worth having every year, not just once. The eighth one bothers me the most because of how it gets used. Atypical antipsychotics, drugs like quidapine and risperidone, brand names like Seroquel, they have real uses, but they are handed out far too often to older adults simply for sleep or for the agitation that comes with dementia. They hit two levers hard. They disturb your metabolism, driving weight gain and blood sugar up, which ages your arteries. And they can change the heart's electrical timing, setting up a dangerous rhythm. On top of that, the FDA carries a boxed warning that in older adults with dementia, these drugs raise the risk of stroke and death. That warning exists for a reason. The danger is the quiet prescription for sleep that turns into a nightly habit nobody revisits. So, here is what to do. If you or someone you care for is on one of these, mainly to sleep or to settle agitation, that is the one to question first. Ask the doctor if it is truly needed, whether the dose can come down, and what non-drug options exist for sleep or for calming. And like the steroid, this is not one to stop abruptly. It comes down slowly with the doctor's steering. The ninth is the prescription painkiller, the opioid. The pills like oxycodone, hydrocodone, tramadol, often given for chronic back, joint, or nerve pain. Most people think of these as a breathing and addiction risk, and they are. But there is a heart story too. Opioids dull the part of your nervous system that steadies your heart rate and your breathing overnight, which is hardest on an older heart. A 2016 analysis in the journal JAMA found that long-acting opioids were linked to a higher rate of death from heart causes compared with other pain treatments. The risk builds in the person on them month after month for pain that never fully settles. What to do if you are on a long-term opioid? The goal is not to suffer. It is to find the lowest dose that keeps you functioning, and to ask your doctor about pain approaches that do not run through the opioid system at all. Things like physical therapy, certain nerve medications, and targeted injections. And the rule you already know by now. You taper this one with your doctor, never on your own. Let me put all of this together with a patient I will call Raymond. 68, retired electrician, lives outside Cleveland, the kind of man who mows his own lawn and has never missed a pill in his life. On paper, he was doing everything right. He walked his dog every morning and took his blood pressure pill on schedule. But his pressure sat in the 150s and would not move. And one morning, his heart was fluttering in a way that scared him into my office. So he laid his whole cabinet out on the desk. ibuprofen every single day for his knees, an over-the-counter heartburn pill he had been on for years, a decongestion he took most mornings for his allergies, and a thyroid dose set 12 years ago that nobody had rechecked since. 4 ordinary things, 3 of them bought without a prescription. All 4 pulling on his heart at once. Raymond did not need a new medication. He needed 3 of his old ones looked at. We rechecked his thyroid and brought the dose down, which settled the fluttering. An early atrial fibrillation caught in time. He swapped the daily ibuprofen for a topical gel and acetaminophen. He dropped the oral decongestant for a saline spray. Within a couple of months, his pressure was in the low 130s. His rhythm was steady, and he told me he felt like himself for the first time in 2 years. Same man, same kitchen, a few quiet corrections. Here is the single thread running through all 9. Every one of them works on the same 4 levers I gave you at the start: pressure, clotting, vessel tone, rhythm. Once you can see which lever a pill is pulling, none of this is mysterious anymore, and you stop being a passenger. That is the real point of today. You do not need a medical degree to protect your heart. You need to know that the pills themselves can be part of the problem, and you need the right question for each one. Your medicine cabinet is one of the few places where you have real control, so start there tonight. First, gather every medication you take, both prescription and over-the-counter, and write them all down. Over-the-counter medicines matter just as much as prescriptions. Next, check your list against the 9 medication groups we discussed: pain relievers, decongestants, steroids, hormone therapies, thyroid medications, acid-reducing medications, autoimmune treatments, sleep or anti-anxiety medicines, and opioids. Then, choose the one question that matters most for your situation. If you take a thyroid medication, ask whether it's time to recheck your TSH. If you rely on a daily NSAID, ask about safer long-term pain management. If you've been taking an acid-reducing medication for a long time, ask whether stepping down is appropriate. Finally, bring your medication list, or better yet, the actual bottles, to your next appointment. Placing everything on the table gives your healthcare provider the clearest picture and can uncover problems that might otherwise be missed. One final point: never stop or change any prescribed medication on your own. Always discuss changes with your healthcare provider, since some medicines need to be reduced gradually or require close monitoring.